Good morning. Welcome to Instagram Live with Dr. Michael Stein. And I am sorry we were having some technical issues this morning, but so honored to have a special guest here today to talk about pain after a mastectomy. Can everybody hear me now? Can you ladies hear me? Give me 1 second, ladies. Dr. Stein is trying to join as this morning is Instagram doesn't want to cooperate. Oh, good morning, Dr. Stein. Thank you so much
There
for
we
joining
go.
us.
Apologies for the technical difficulties. You guys can see me now?
Yes, we can. Thank you. It's Thursday. It's technical Thursday, right?
Yeah, my apologies. Anyway, we're good now. So what did I miss?
Perfect. So I was just telling everybody, we're coming on this morning. We had a special guest, Dr. Stein, coming on to talk about pain control after a mastectomy. And some women are already starting to comment, and I'll
Yeah,
go back
sure.
and ask you the questions. What I'd
Sure.
like to do is basically, again, for those of you that don't know me, I'm Tracy Milgram, the founder of BRCA Strong, where we educate, inspire, advocate, and support survivors, and thrivers, regardless of predisposition. We're here to eliminate the feeling of isolation and help you feel whole again. We do that by providing pre-mastectomy care packages prior to going into a mastectomy, chemo packages, and as well as a program called Bras for Brave Beauties, where we fund women bras and lymphedema sleeves. And knowing how important it is, especially during our COVID-19, just making sure that our continuous education is really being given on a weekly basis and making sure that women know their options and knowing more information about a mastectomy. And something that is really important to me is pain after a mastectomy, pain control, avoiding opioids, getting the word out there about nerve blocks. And I was honored to come across Dr. Stein's profile on Instagram, seeing some of the pages that he's published, and just seeing his outreach in the community to continue to make a difference. So today, thank you so much, Dr. Stein, for coming on. And if you want to do a
Thank you.
short introduction, and then, we can go right into the program, and then I already have some questions and we can
Sure,
talk more
sure.
about it.
Yeah, no problem. Well, thanks again, Tracy, for inviting me to come talk to you guys today. Great initiative. You're doing some great things and helping a lot of people, so congratulations. So briefly about me, I'm a fellow at Lenox Hill Hospital. We do a lot of breast reconstruction there. And as you mentioned in your post, I'm also doing a master's degree through Johns Hopkins University, where we deal with patient safety and healthcare quality and basically a lot of safety around surgery. So I have a specific interest in improving outcomes after breast reconstruction, and pain control remains a big issue after mastectomy. So we're going to be talking about that today. So I thought maybe we would just briefly talk about broadly the different modalities we have to control pain, and let's keep this as informal as possible. So interrupt me whenever you want, or if someone has questions that's relevant, just feel free to interrupt. So why is pain a problem? 40% of mastectomy patients experience acute pain after surgery, and some studies show that up to 60% of patients will develop chronic pain. And chemotherapy can lead to peripheral neuropathy, which we find in about 68 or up to 68% of patients in the first month following chemotherapy. So it's a pretty significant problem. So postoperative pain is bad because it leads to a poor recovery, a slower recovery in patients, longer stay in hospital, poor patient satisfaction, and the potential for a development of a chronic pain syndrome. And historically, pain was largely controlled through single modality opioid analgesia. And we've transitioned away from this. We've transitioned away from just opioids to more complex multimodal pain therapy. And the widespread reliance on opioids has really fueled, as we all know, an opioid epidemic in the United States. And this has devastating societal and economic consequences. So we want to do whatever we can to control the pain the best we can while minimizing the use of opioid analgesia. And don't get me wrong, opioids have an essential role to play and will continue to have an essential role to play, but they must be prescribed in the context of multimodal therapy. So the first thing is patients need to discuss with their surgeon their history of nausea, vomiting, and their history of pain in the past after surgery, because we can predict increased pain based on history and change our regimen accordingly. So what are the predictors of nausea and vomiting? If you're female, if you don't smoke, if you're undergoing a long surgery with general analgesia, or anesthesia rather, and if you have a history of nausea and vomiting in the past. Postoperative pain predictors are obesity, younger age, history of anxiety or depression, and preoperative pain in the past. So all pain regimens are unique to the patient and should be modified accordingly. So all this stuff's really important to tell your surgeon. Broadly speaking, there are there's two real classes. There's multimodal pain medication, which is really synonymous with ERAS, or Enhanced Recovery After Surgery protocols. This just means concurrent use of multiple different classes of medications to limit the use of opioids. And the other class is regional nerve blocks, which could be paravertebral blocks, epidural blocks, Pec Serratus blocks, or transverse abdominis plane blocks. And I'll get to all of those things. But patients who engage in collaborative care and shared decision-making with their provider experience better health outcomes. And this is really being borne out in the literature. So we really need to empower patients by educating them the different options they have with respect to their postoperative pain regimen. And they need to take an active role in their pain regimen before their surgery. So the first thing I want to talk about is enhanced recovery after surgery. These are evidence-based protocols that are shown to decrease pain, reduce opioid consumption, and decrease length of stay in the hospital. And they're really a combination of things that we do preoperatively, intraoperatively, and postoperatively. Preoperatively, we counsel the patients. We set a goal of not zero pain, but tolerable pain. We describe the degree and duration of pain that they should expect. And we explain the issues of narcotic analgesia and our plan to maximize non-narcotic analgesia. And so this really pertains to using Tylenol, Celebrex, gabapentin, aprepitant or Emend for nausea and vomiting, all together preoperatively in anticipation for the surgery. Then, during the surgery, we limit the amount of opioids given by the anesthesiologist during the case. We give IV Tylenol during the case. We give ondansetron. Sometimes we give steroids. And we perform these blocks that I'll talk about shortly. And then postoperatively, again, multimodal analgesia, different types of pain control, and then only using opioids for breakthrough pain, which could be any type of opioid. We use Dilaudid most commonly. So, and then regional nerve blocks. The principle behind regional nerve blocks are pretty basic. Local anesthetic block sodium channels on nerves and block the propagation of the nerve signal. And when we use it, we target certain nerves and basically freeze them. And we freeze them for a certain amount of time. We can use bupivacaine, which is a long-acting anesthetic, to block the nerve for hours. And at times we use Exparel or liposomal bupivacaine, which provides analgesia for up to 3 days postoperatively. And these blocks can be performed by surgeons and by anesthesiologists before the case. So the first one I want to talk to you about is paravertebral blocks. This was really the impetus for giving this talk, or for inviting me for this talk altogether. Paravertebral blocks work. They are typically given by an anesthesiologist before the case. They are given under ultrasound guidance. And they basically block the nerve roots T1 to T6 that exit the intervertebral foramen around your chest that come around to provide sensation to the breast. So in the study that you just described that I wrote a couple years ago, we basically took 300 patients and 112 of them had standard pain protocols and 186 of them had the paravertebral block. And we found that the patients with the paravertebral block had better recovery, decreased postoperative pain scores, required less opioids, and went home faster with a very low complication rate of 3%, which was all minor complications. And other studies have supported this. Paravertebral blocks are associated with less nausea, vomiting, less pain, happier patients. Another
How
block,
long?
uh-huh.
Somebody is asking us, how long does the nerve block last, and can you get one after surgery?
It's a great question. We use, like when I talk about tap blocks, we use liposomal bupivacaine, which is an ultra long acting anesthetic. So it lasts up to 72 hours. It's different for everyone. Some people, it lasts 24 hours, but reports are up to 72 hours. And bupivacaine is like 2 to 6 hours after surgery.
Okay.
So again, different for everyone, but we're talking hours versus days between those two types of anesthetic.
And can you get one 3 days? One of our girls is asking, she had a mastectomy 3 days ago and is asking, is she able to get another nerve block due to the pain instead of doing opioids?
So instead of doing, like, she had a, what kind of nerve block did she have? Did she specify?
Let's see. Hold on. I'm going to tell you right now.
In general, you should always you can have opioids on board, but to be taken on a PRN basis. So it's not like, you get the nerve block and instead of narcotic medications, you can get narcotic medications if you need it, but you need to exhaust every other modality, including a nerve block during your surgery and multimodal pain medication. And then if that doesn't work, you take your breakthrough pain medication, which is your opioids.
She didn't say what kind of nerve block, so maybe,
Typically it's
Veronica, Veronica, if you're on, send me a message back and let me know what kind of nerve block you had, and then we can try to answer your question.
In general, though, you perform one nerve block,
Okay,
so you don't get multiple.
perfect.
Any other questions before I go on?
Not as of yet.
Sure. The second block I want to talk about is Pec Serratus Blocks. These can be done under ultrasound guidance by your anesthesiologist before the case, or can be performed by your surgeon during the case. We routinely do these. These anesthetize the medial and lateral pectoral nerves as well as intercostal nerves, and they work great. We perform them intraoperatively because it's under direct visualization, but a lot of centers, including the one I used to work at, use ultrasound guided blocks preoperatively by the anesthetist. So another study you mentioned was a study I wrote on latissimus dorsi flap reconstruction. So in this study, we had 20 patients who were enrolled in this ERAS group that had the serratus block, the Pec Serratus block, and 58 patients who had traditional treatment. And the patients who got the nerve block, 100% of them went home the same day of surgery, as opposed to 20%, which stayed a couple days after surgery and weren't successfully discharged after 24 hours. So they were associated with better patient satisfaction and earlier discharge.
So what's the advantage over one block over the other? Is there an advantage to one over the other, or is it patient specific?
It's a very good point. There's a couple of different things that go into it. One is how extensive the mastectomy is. If you have a tumor that's invading the pectoralis major muscle, you might want to get a more comprehensive block that includes the Pec Serratus block. If you are getting a latissimus dorsi flap reconstruction, there are nerves involved in your back, because that means you're taking the muscle and skin from your back to swing into the breast. There's different nerves that you need to cover based on what kind of reconstruction you're getting. So all of them work, but you need to really tailor it to the specific surgery you're doing.
Okay.
Yeah.
Can patients request? Go ahead. Sorry.
No, go ahead. Go ahead.
Can patients request one over the other, or do you think that basically you're better off? Obviously as a physician, our goal is knowledge is power, right? But sometimes, obviously, when you go in there, is it worth it just to say, do I qualify for a nerve block? And if so, which one? For those who are listening out there who are just headed in for mastectomies, I personally know 6 years ago when I had a mastectomy, the nerve block saved my life.
Yeah.
But I don't know which nerve block it was. Now that I think about it, I didn't even know that there was two kinds of nerve blocks. Obviously
Yeah.
there's different locations from where you're doing it. But like to educate our community a little bit more on it, is most women don't even know about nerve blocks. You know, what is a piece of advice, I guess, that we could give them to share with their physicians?
Yeah. I mean, I think it's a great question, and that's the main point I'm kind of trying to get across. It's important as patients to empower yourself with the knowledge of different options out there and to take an active role in your postoperative pain plan. Once you're sitting in your hospital room or at home and experiencing pain, it's not the right time to question why this is happening and what options do I have. You shouldn't be looking at your pill box and questioning how they work. It's best to participate in shared decision making with your doctor, which means together coming up with a detailed perioperative plan that may consist of multiple different pain medications and intraoperative nerve blocks. And ideally, you should have a printed plan that you have physically with you where you can look at your medications. You know what you got intraoperatively for your nerve block and what medications you're prescribed, and you understand why they work and how long to take them. And exactly as you said, asking questions is so important. You're a team, you and your surgeon. And like any other aspect of your surgery, you need to ask them questions if you have any concerns. So you need to be asking, what kind of medications do I take pre-operatively and post-operatively? What kind of nerve block are you performing and why? Some people might propose, a Pec Serratus block, which is better for a latissimus dorsi flap, when they don't really need it. They might be good with a PEX 2 block or a paravertebral block. So every surgery is different, and the nerve block needs to be tailored accordingly, and every patient is different. So based on your history, your ERAS protocol can be tailored accordingly.
How come nerve blocks aren't spoken about more? Just out of curiosity, like they're not, like ICU obviously tailored to this specifically, but many in our community, really don't talk about it. Even our big centers, like why aren't they spoken about more?
I think, people are doing it, and there's more and more literature to support their efficacy. And I think patients need to ask for it because they work, and efficiency is a main issue sometimes because they take time. They sometimes delay the start time of the surgery you're going to undergo, and from a patient perspective, they're uncomfortable sometimes initially when you get them. And so because there's not a lot of knowledge surrounding these nerve blocks, patients it spooks them out. They don't want to get a needle poked into them before their surgery. They have enough anxiety undergoing a mastectomy, and they don't want to get another procedure done with its own, potential complication rate. So I think with more knowledge and more literature to support its use, there'll be more and more people doing it.
Somebody had a question. What about a nerve block with a fat transfer?
So I've never heard of a fat transfer with a nerve block, but they might be discussing what liposomal bupivacaine is. So bupivacaine is one of the local anesthetics I described, and liposomal, there's a carrier that allows it to be in your system for longer. So I think that's what they're asking about. So yeah, that refers to Exparel, and we use Exparel all the time.
So say I'm undergoing mastectomy and breast reconstruction next month, what would you suggest I do? Like, as a physician side, I'd love to hear what you would kind of guide us and advise is, obviously you guys are on that side and then coming on this side and hearing it from the patients, but obviously this is no medical advice given. So like from a physician side, maybe you can express, what would you suggest to do?
I would suggest well before your surgery, you meet with your surgeon and you have a detailed discussion with him or her describing your history and your concerns about the surgery. And together you have this bi-directional discussion of what's important to you guys, and you come up with a detailed plan. and print out that plan. So know what's going on, a month before your surgery, a week before your surgery, what's going to happen during your surgery, and what's going to happen after your surgery with respect to your pain. And, be really engaged in your care and ask questions. If, I would suggest everyone to ask about ERAS protocols because the evidence is so strong to support their efficacy. And nerve blocks, they might not be for everyone, but they are safe and effective. And every patient should feel empowered to ask their surgeon before the case, can you do this? Can the anesthesiologist do this? Is it safe? Which one do you think I need? I think that's the way it should go.
I definitely feel, that's why it's so imperative to make sure that you're comfortable with your team so you can ask these questions and making sure that you're able to provide what you need. So asking ahead of the time,
For sure.
I feel like it helps us instead of hurts us, where many of us are hesitant to say, should we ask our doctor? No, we should always ask, and don't be hesitant, don't be shy, because no information is too much information at this point.
100%. You should never hold back. If you have questions and it's going to put you at ease and it pertains to your health, 100% you should ask your surgeon, anesthetist the morning of. Ideally, you don't do it as you're being wheeled into the operating room. Can I get a nerve block? This is a plan that really has to be planned well in advance.
Right.
But yeah, definitely a good idea to have open communication and not to feel embarrassed to ask any of these questions.
I'm super thankful for you sharing all of the information on nerve blocks and, coming on to educate the community and making a difference and continuing to let our women out there know what's available for them, right? If we can eliminate more barriers, saying, hey, listen, ask for a nerve block, know what a nerve block is, know there's 2 different kinds of nerve blocks, before you go in, to eliminate the pain, as much as we can. Obviously, nothing's ever guaranteed. Like you said, it could last a day, it could last 72 hours, but just knowing this information is crucial, and figuring out how we can help our women become more comfortable, especially as I know you see in many women, it's never easy to undergo a mastectomy and to face all of the journeys that we face and face some of the complications, but knowing what we can do to avoid pain and to avoid another barrier that somebody could hit. And if we can help take that pain away, it should be spoken about more. And, the papers that you publish and the ARIAS paper and all these papers that are published are such crucial data. And I wish that in our community, I could say that we had more access to this. So as you find papers or you write papers, we would love for you to share them to show these women evidence. I know personally, I'm a true believer on evidence makes me, think harder. When you hear somebody, well, there's this nerve block and, it might work, but you don't know. Obviously, like we said, every patient's different, but reviewing a stat and reviewing the clinical data that has been reviewed and sent to the IRB and sent to different standards, I think is so imperative. And
For sure.
I always, and so we are always so thankful for our physicians that come on that share information like this, because some women don't have these resources, and knowing your resources and having them, to me, just eliminates barriers and helps women with less anxiety. We all have enough anxiety, from scanxiety to going into your mastectomy, and and even women who are taking preventative action or survivors, these are all options that are available, and knowing them up front, I think, really makes a difference in our community.
Definitely. I agree with all of that.
You're definitely at a great center. I mean, Lenox Hill, and you have the BRCA Center right there, I have to say that I will definitely give credit. It's probably one of the best centers that I've ever visited in the US, and I feel like if every state could have a BRCA center like you guys have, life would be really different. And I think women would be more educated, and not only from the BRCA side, but from the breast cancer side, or knowing your risks, or knowing, because the different ethnicities have higher, rates. Like, these are all things that are just so imperative in our community, and we're grateful to have physicians again like you to come on and educate us. So we definitely would love to have you back on.
Anytime.
And we really appreciate it and look forward to speaking with you in the future and having you come on maybe and talk about some flaps and different flaps that we have, as I know you specialize in, plastic surgery and the different procedures. And knowing what we can do in that side is there's really no gold standard, you know, for deep flap or for latissimus flap or the pap flap that now people are talking about. And I feel like I personally have just learned more about the pap flap and nobody's really talking about it. You know, we start all these different flaps and master the deep flap, but then now there's all these other flaps, right, that go along with it. And we're just out there talking about them, but not really taking the time to educate, I feel, and explaining to women, like, it's on the back of your thigh versus your back or versus your stomach, you know, and talking about what we can do to eliminate that for women as well and figuring out how we can continue to educate.
Definitely, definitely. Exactly as you said, there's a certain extent a disconnect between the medical literature, which you have to, you know, subscribe to and pay to get the journal articles, and so, you know, the people that we want to educate and that should be empowered with all of this knowledge they're not getting this information. So I mean, I'd be happy to come whenever you want and share my papers, and everything you're saying is totally correct.
Definitely. And, you know, as you have papers, send them to me in an email. We can upload them and share them with our communities. I feel like that kind of gives women a different perspective. You know, when you see stats and the efficacy and how it's working. I mean, my background's a little bit of clinical research, so I know about, like, you know, showing the women in different groups, right? Like Black African American women versus white women and the studies and how you heal. I mean, this data isn't out there unless, like you said, you pay for it. And, you know, we're a grassroots organization and it's hard to keep up with everything. So when we connect with physicians like you that are willing to share and communicate and help us educate, I think that it gives women a little bit of a peace of mind and sanity, knowing that they don't just have to dig out there, right? Because when you type in breast reconstruction or you type in DFLAP, you know, you're getting centers all over the world. You're not getting centers in your state. You're getting information from websites that might not even be accurate.
Right, right.
So,
We
well,
agree.
if anybody missed this call and you guys are just tuning in, you can feel free to watch it back on Instagram Live or in our YouTube channel. You can always feel free to send myself a message and I can reach out to Dr. Stein.
Or you can email me directly. You know, I'll give you my email to post, and any further questions, comments, happy to communicate with anyone who wants any more information.
Perfect. Well, I hope you have a great day and thank you so much for your support and time.
My pleasure. Take care.
Perfect. Take care. Bye bye.